I think there's a huge opportunity to shift our attention to keeping people healthy.
This is a conversation we need to be having with our civic leaders, with our business leaders, because at the end of the day, a strong health workforce is the foundation for a healthier community.
The people working inside that health center are also the community. What happens when the nearest hospital is 40 miles away? Or to access a provider, maybe you try to use broadband or internet, but it's unreliable, and so it's really hard to connect with your providers. Unfortunately, this is a reality for a large segment of the country in rural America. I'm Amanda Pears Kelly. I'm the CEO of Advocacy for Community Health, and this is Community Health Centers Unfiltered. It's a podcast where we talk about the policy and the politics and the people who are doing the work to make sure that people have continued access to care in a health center setting, but also here in Washington to make sure that policymakers and decision makers understand the implications of what this can look like and the realities of what it is to live in rural America and how to access community health centers and all of the patients that are impacted by the policies they are putting in place every single day. So we're turning our focus to rural America because the health disparities that exist in that space are very real and very impactful. And it's incredibly important to make sure that the policy decisions that are made lend themselves to addressing those health disparities, because that is the right thing to do, and the people living in rural America deserve that. Rural does not mean forgotten. It also doesn't mean powerless. And so that's part of the reason for the conversation today, and also what we're going to be discussing in terms of what people can do coming out of this. Community health centers are showing up every single day to make sure that people have continued access to care in rural America. They are a huge part of the solution when it comes to this discussion, but they are also experiencing the same challenges and barriers, whether it be infrastructure, workforce, funding in order to secure the resources they need in order to continue providing that care, or to expand into areas where rural America has not been reached or continues to lack access. So I'm really excited today. We're going to be speaking with Michelle Rathman. She is a healthcare strategist, and she's the founder of the Rural Impact, a podcast where we're connecting dots today and in her discussions about the connection between geography and equity, between funding and access, and all of the policy in between, and how it has an impact on these very, very important issues for rural America. So with that, let's go ahead and get started. It's going to be a great conversation. Well, then let's jump in. Michelle, obviously you get a full intro here, but I would love for you to introduce yourself and just tell us a little bit about who you are and all your amazing work.
Well, thank you again, Michelle Rathman. I am the CEO and president of Impact Communications, Inc., a company I started in 1989, which is a number I can hardly wrap my brain around. My work for the last 25 plus years has been in rural health. Prior to that, I worked in urban health, and I saw a great deal of similarities between the two, and still do work with rural health or academic and urban health organizations as a means to help collaborate and strengthen the entire health system. So I've had the joy of working with rural hospitals, rural health clinics, community health centers, and with rural health organizations across the country, including the state offices of rural health. And for 8 years, I managed with my team National Rural Health Day, and our charge was to help transform a moment into a movement, and so and really coin the phrase "power of rural." So that is a little bit about my rural health roots, if you will.
Well, those are deep roots, and we're grateful for that. I also love to hear the call out to community health centers, because obviously that's near and dear to us. But just to get us started, I would love for you to give us big picture. What does the state of rural healthcare look like in America right now?
Well, if you were going to ask me this question about 18 months ago, I would have told you that we're making great strides in addressing the social drivers of health. There was a recognition several years ago with the expansion of the ACA and Medicaid, where we were able to insure a whole lot more people in rural communities. But as of right now, and with the passing of HR 1, known as the One Big Beautiful Bill, things for rural health in particular, I say rural has definitely come out of this as the biggest losers on so many fronts. So I will say that right now the mood is somber. And there's going to be some significant challenges, ever more still for rural health organizations as we move forward. And some of those aren't going to hit us for a while, but be assured that they are in our very near future, that we're going to start to feel some of the pressures that this new legislation has put forth.
So it's really interesting that you say that, because I feel like the understanding headed into the work around the One Big Beautiful Bill, and honestly, a lot of the conversation around healthcare has really been focused on the needs of rural communities and why that needs to be elevated. So we'll get into it more, but I just want to follow up to say, where do you see the most urgent gaps right now in terms of what rural communities are coping with?
Well, obviously, the big gap is just access to healthcare, and our rural healthcare workforce since COVID has been, really challenged to kind of build its bench, if you will. So rural health in general and access is a big challenge. But I'll just share with you, I spent a week in March traveling across the entire state of Massachusetts, for example. And this was a part of a project that involved helping to understand the impact of the work of community benefit organizations, and they were recipients of our Rural Vaccine Equity Grant dollars. And while the project was really focused on boosting access to vaccines, in that it did, what it also did was expose what we know to be true across this country, which is rural communities struggling with housing security. Safe housing is a very important issue. Transportation comes up over and over and over again. Folks think, well, why can't they just, why do we have worse health outcomes in rural? There's a well-known true narrative that our rural populations are sicker, and not just older and poorer, but sicker, and there's a reason, and that has to do with access, and transportation plays a big role in that. And of course, another threat that we're seeing increasing is food security. We had significant challenges in food security during the pandemic, and now again because of new legislation. And what I really work to do in my work and in my podcast is to connect the dots between policy and all of these things. So at the end of the day, when you decrease access to healthcare, when you decrease access to healthy food and nutrition services, when you aren't investing in things like transportation, it really does cook up the perfect storm, as they say. So
I couldn't agree with you more. And honestly, the ripple effect that you're talking about is something that we've been talking about quite a bit as it relates to community health centers. Because when you pull one lever, that ripple effect just goes across the entire community. And I think in rural areas, it's that much more dire because you don't have someone to step in to take up the slack or someone to step in and fill that gap. And so this is another one where I feel like we can have a lot of conversation about it. But I do want to, for a second, talk about the role that community health centers play and sort of how they're uniquely positioned to be able to meet some of these needs where other providers can't, or quite frankly, where there's a lack thereof entirely.
Well, I have recently done a project, which I'm so proud to say, with the National Association of Community Health Centers, and the catalyst for that work was to really showcase the power of partnerships and collaboration between community health centers and critical access hospitals, for example. And the conversations that I've been having with community health centers and over the years, and not just this project, really is that they have, I think, more bandwidth in terms of being able to meet community members where they are, and that they don't turn anybody away regardless of their ability to pay. They are really well positioned to be to have staff that is sensitive to all the nuances of the particular community, cultural sensitivities. They have history with their communities in different ways than perhaps other health organizations have. So I think that they are, our best bet for the safety net to stay strong. And my hope is that there'll be some change of course, if you will, on the funding for these centers, because in urban and rural alike, they play an essential role in improving population health. And as I said, meeting patients where they are with dignity and respect, and not that the clinics and hospitals I work with don't, It's just a very unique setting and a very unique mission.
Well, that's music to my ears. I need to take you on the road with me, Michelle, because you're speaking the same language. But you said something that I really want to pull out because I think it's so important. And that is that health centers treat everyone regardless of their ability to pay. And the reason I bring it up is that there are very few, I think, if any other providers, maybe emergency rooms, where that's the case. You have free clinics, you have others, but health centers are bound by statute, but also by mission, and they treat their patients in a very different way. But I appreciate you calling that out. One of the other things I think is worth kind of pausing on, or at least looking at, is some of the things that rural communities across the country face, the barriers that they face to accessing care and otherwise that folks in urban areas probably don't even think about, they don't consider. Do you want to speak to that for a minute?
Oh yeah, I mean, I think just kind of, we'll just go back to, let's just take a look at that which most of us take for granted, which is transportation. You know, there is no rural community that I've been to as of late, and I've been to many. I just wrote a piece that I'm working on. I mean, I've traveled over 100,000 miles and then some across rural America. And, you know, for those of us who live in more populated areas, you could just, you know, get on an app and get on your phone and get an Uber somewhere. Well, there are some really innovative solutions. I can think of so many communities that are chasing, you know, constantly chasing grants to solve their transportation gaps. And so when we think, well, why can't they just get to the doctor or, you know, follow up with their care? Well, when transportation is not available, and we have so many rural communities where they think, well, there's, you know, they could just, you know, ride a bike or walk. Well, I mean, there are so many parts of this country where that's just not possible to do. And we shouldn't expect our rural populations to just find ways that, you know, that modern technology could actually solve and then have them locked out from the infrastructure. And the other one would be that broadband. You know, as I am sitting here talking with you today before we recorded, you know that we lost our power and our internet. And when you think about communities that literally are broadband deserts because it's just cost prohibitive for the carriers. So it's not, for rural communities, if it's not a profit center for an industry to invest in, rural communities are locked out of those opportunities. And the fact that we are in 2025 and we still have broadband deserts and transportation deserts is quite astonishing to me. The way is there, but the civic and political and financial will is not catching up.
Yeah, it's really hard. So my little history on me. So I was born and raised in Maine, and I mostly grew up in the southern part of the state, but spent a lot of time in the northern part of the state, central and northern part of the state. And I mean, to your point about transportation, it's 45 minutes to an hour to get to population centers where you're going to be able to get to the grocery store, get to a doctor, and that's just standard. You know, that's where you live. But I think between the issues with connectivity, but also when you think about cost, you know, I think it doesn't necessarily occur to somebody that has all of these resources in a short kind of circumference from where they live, the cost of driving 45 minutes or an hour, literal cost in terms of gas in your car, but then also cost in terms of time and how you're coordinating that. Maybe you only have one vehicle. There's just so many different things when I think about our patient population and what it looks like in rural communities. But I also agree with you 100% in terms of the connectivity. I think there's this assumption because of the world that we live in many parts of the country or corners of the country where, oh, you know, if you don't have Wi-Fi, you at least have, you know, cell phone accessibility. That's not always the case. It's also not reliable necessarily. And we obviously just went through the technology woes ourselves earlier today. So yeah, it's a very different reality. It can be quite beautiful, but it isn't without its barriers. And I think it's incumbent upon us. A lot of the work that we do obviously is around how do we address the policy. I know this has been, you know, decades of work for you too. Is there a specific story or an example that really kind of stands out to you just in the years and years that you've been doing this work where it just struck you as, my gosh, you know, maybe it wasn't even something that you had been thinking about in the past?
Well, gosh, where to start? I mean, I just think I reflect on a place that I went last year, and I really do work to protect, you know, communities because it's not saying anything negative at all. I went to a community where literally there was not a single grocery store, nowhere to be found. I mean, 75 miles to the next nearest hospital, 45 miles to the next grocery store. And, it did not have a community health center. There is only one critical access hospital, one provider practice, and they were, it had been 30 years since they had a levy increase. And, I'm taking a look in particular about, some of the different models of healthcare. So when you were talking about a community where it's a public entity, a public health district, or a public hospital district, the community does not have the financial means to continually invest in their facility. And so it is really run on levy support. And so I think about those communities that right now, are doing everything they can to keep their lights on and to not even be able to have places where healthy food is accessible. I just think about how the map is going to be dotted differently from communities that have lost everything. And it seems like such a grim picture for me to paint. And honestly, I am a very optimistic person normally, but these are some of the stories that I think about why it's so important for us to advocate for those who don't have the resources to advocate for themselves. Because in the end, I really believe that one community without health care, there is a ripple effect and almost kind of an avalanche effect, if you will. And people get buried under this disparity. And it's not good for any of our neighbors to be in that position. So it's a culmination of those stories of communities that have really been impacted by the loss of services. And on the flip side, the joy that I feel when a community actually has been able to raise the capital, gain access to capital. When we talk about some of the roadblocks, I think access to capital is a biggie. But when they can, and those doors open to a new community health center or the doors open to a new critical access hospital, the sense of pride, the sense of hope that comes back, the revelation that this represents jobs and the multipliers as well. So while we have so many places where there's deficits, we do have some success stories where communities have been renewed because healthcare has been restored and built back better.
No, 100%. And I think, a lot of these communities where the health center is actually one of the largest employers in our rural communities, and we were talking about the ripple effect earlier, that's another piece. It's sort of you're providing care and you are the access for the community, but then the people working inside that health center are also the community. And so there's economic drivers, obviously large employers, all of it. But speaking of employment, a couple things I wanted to flag and a question for you. So I think the way you just framed that was so perfect and so beautiful. And it reminds me, we have a fantastic member health center in Kentucky, Mountain Comprehensive. And they built a workforce program called RAISE, where basically within the four walls of their organization, there's opportunity for training and education at no cost. They have incredible partnerships with their academic institutions in their wider community. They've done wonderful fundraising, grant writing, et cetera. But it has completely changed and transformed the community. They went from having workforce shortages to now having a wait list to work at the health center because for one of the first times, and for many people for the first time ever, they are able to not just access employment, but also upward mobility to gain greater training. And it's not just in the clinical space, it's really kind of all four corners, like I said, and across the healthcare workforce. But workforce is an issue that is so near and dear to my heart. I have the distinct privilege of wearing a couple different hats. And in one of those hats, we focus very heavily on healthcare workforce for underserved populations in particular, so much of which is in rural communities. But I would love to hear from you when we talk about workforce shortages in rural areas. How are community health centers navigating that challenge? And are there policy changes from your perspective that would really make a difference in terms of how they continue on in that space?
I think workforce in general, community health centers, rural health clinics, everyone is competing for the same talent pool. Honestly, that is, there's just no escaping it. And what I'm seeing is very promising is one of the case studies that I wrote for this project with Nat that I mentioned earlier. And actually, there's two of them that have a workforce component to it. One of them is a critical access hospital and a critical access hospital and community health center that partnered to launch a combined rural primary care residency program, which is an outstanding way to go because, better together is my philosophy. And they are referral partners. I mean, each of those different kinds of healthcare delivery organizations, they can't have every slice of the pie. It's not meant to be that way. So I think collaboration is key. There was another case study that I wrote about, and I love when academic medical centers and the university programs partner also with critical access and community health centers. There's one out of Oregon that's just an outstanding example of how you can create a primary care family medicine residency track that serves the hospital and the community health center and the Indian Health Services. And so I think my number one observation right here is that there is a full recognition that co-recruiting is a far more fruitful exercise than everyone just kind of going out there and trying to offer more benefits, more money, and so forth. Because what we do know, I did some work with the National Rural Recruitment and Retention Network, 3RNet as it's known, is that those who serve or those who the health workforce going into community health centers or rural or underserved, there is a different motivation, and I'm not assigning any negative or positive to any other underlying motivating factors, but there's a mission motivation. Yeah. And those who want to practice in underserved or under-resourced communities do so because their insides tell them that they can affect change in a different way than being with perhaps a bigger system or concierge medicine or what have you. We all make choices based on what our preferences and what our life goals are. So I think that the collaboration piece, everyone wants to work in a community where people get along. I've seen, and you probably have too, where there's been some friction, for example, between competing health entities. That never serves a community well. I have seen that go downhill real fast. It diminishes trust. And so I would say some of the, looking forward, if we look in the rearview mirror, we're only going to see where we've been versus where we're going to go. So if we're looking ahead and taking into account the significant challenges, for example, and I just read it the other day to refamiliarize myself with it, in this new legislation, unfortunately, those who want to enter the profession, they're going to see some changes in their loan forgiveness, for example, their ability to access funds for their education. So I think anyone, and when I say we, I think anyone in a leadership position within a community health center or a hospital, really taking into account the roadblocks that are being placed for those who dare to go down that path and serve these communities' healthcare needs. So I would say collaboration and really understanding, how to help navigate around those roadblocks are going to be super important, and those are going to be the organizations that end up not only recruiting but retaining. And I also believe that the Grow Your Own programs are essential, and not just in the clinical side of things, because we know that everything around IT and AI and coding and billing, all these things are constantly evolving, and these take skills as well. And so making sure that you're working with your local high schools, your grade schools, your middle schools, and introducing those subset careers that are not just clinical. And then the last would be just really looking at your leadership bench. I will say one of the things that I don't think focus enough attention on is how do we look at recruiting board members. They, as you know, play an essential role in guiding principles of any rural health organization, be it a community health center or critical access hospital. And so we have to make sure that even though we're trying to fill the pipelines down here, we have to make sure that the leadership of these organizations are prepared to meet the challenges of the moment as well.
Well, Michelle, so many gems from what you just shared and lots of things that I just want to kind of reflect back also. So for one thing, the health professional education and training programs is sort of homegrown, if you will. We see an increasing number of those across health centers. And sometimes it's by necessity because they just frankly, they can't get MAs, they can't get DAs. Nurses sometimes are hard to come by, but I think it is all comers in the healthcare workforce, to your point. But so many health centers have partnered with their local academic institutions to create training programs that carry them through. And one of my aspirational dreams in terms of policy or to create a program is, quite frankly, to create a program that starts at elementary school, because we know the data supports if you don't introduce the possibility of, at least in the clinical space, but I would wager sort of other positions of leadership, if you don't introduce that to kids before age 12, the data supports that their access to that and their vision for that continues to decline. So it really needs to start at the elementary age level. But if we had something that tracked literally in partnership with the health center, with the public education system, with the community college, with all of the different stakeholders in the community to create these pathways that carry them all the way through, whether it be clinical or, to your point, sort of in a more technical space, or it could be operational, could be management. It doesn't matter. It could be community outreach. But I think everyone working together, particularly in rural communities, but frankly in underserved communities in general, to create those opportunities, to me, it's going to take time. One of the reasons that it's aspirational and maybe a little bit of dreaming is that to achieve that, it's going to take about 10 years before you can actually see the return on the investment that needs to be made. And it's hard to compel, whether it be policymakers or foundations or others, to get behind something like that. But I will continue to carry that dream because I so believe, and I'm watching it unfold with certain health centers who have started to really begin constructing not just those partnerships, but the long track and those health professional HPET, health professional education and training programs. A couple of others, though, that I personally, and if you have feedback, but National Health Service Corps is an incredibly vital program. And it's been so distressing to see policymakers who, particularly during the pandemic, were so heavily focused on workforce and made big investments in National Health Service Corps. And at the time, we needed it. You know, people were departing the healthcare workforce space for a variety of reasons, between stress, burnout, early retirement, you name it. But that is a program that has, 50 plus years of proven success, particularly in placing people in rural communities, diversity, you name it. But the resources are going in the wrong direction. I think that the funding for the National Health Service Corps and the Teaching Health Center program, which is also a fabulously important program, also proven to be very successful, the funding's going in the wrong direction. And so from a policy perspective, those are a couple of others that I just wanted to call out because I think, workforce shortages have been challenging in rural areas and I think across the board for decades. And then I think when the pandemic hit, it spiraled in a direction and in a way that I don't know that we ever could have anticipated any of it, but I think it has deepened considerably. And so there's some good things happening and there are positive conversations across policymakers. But to your point, even in HR 1 in the reconciliation bill, there are some things that are dialing back on workforce at a time where we really cannot afford it, particularly in rural communities. But I will get off my...
It doesn't make any sense. No. You take a look at AHEX, I think the line item budget is zero. Moving forward. And so it makes no sense. And it does, for someone who, I sit on the NRHA Policy Congress, we've been talking about staffing ratios, for example, that needing some relief from that because it's not for a lack of wanting to make sure that we have solid staffing ratios. They're not there. And now we have to take a look at, listen, I at this stage in my life, 37 years of business, and turning the corner, and I don't mind telling people, I'll be 59 this year. I've never imagined in my life that we would be at a place where we've gone so far backwards so quickly. And, you and I can have a conversation about the need for equitable distribution of funds, and we can talk about the challenges all we want, but if our policymakers, we say on our podcast, all roads to quality of life are paved by policy. And if ever that was evident, it is today, because we can create amazing programs, and and we don't have to reinvent the wheel. They're out there, to your point, that really do provide these centers of learning and centers of growth within our local public schools. Well, when funding for those kinds of programs goes away, then who picks up the slack? And then when we work with our community colleges and we're creating pathways, I have learned about so many programs from working with interviewing many people over the years on post-secondary education opportunities in rural communities. When the funding for that goes away, then who picks up the slack? So I think part of this, and maybe this is appropriate for this part of our conversation, is that it cannot just be the responsibility of those who work in, per se, health. This is a conversation we need to be having with our civic leaders, with our business leaders, with our chambers of commerce, because at the end of the day, a strong health workforce is the underpinning of it's the foundation, I should say, for a healthier community. Businesses do not want to recruit, or they do not want to move to areas where there is no health care. And so I think, other industries are feeling the squeeze of filling their pipelines too. But I think the healthcare pipeline has got to be the biggest priority for any rural community, in my opinion.
No, I totally agree. I think the other thing that I would connect to this is, and I think there's a huge opportunity here, but when you think about something like Make America Healthy Again, which, there's still a lot of framing and a lot of detail to be brought forward in terms of what exactly is meant by that. But if we're just talking about making people healthy and keeping them healthy, it's primary care. And I think one of the challenges in terms of healthcare workforce, of course, is that right now there is a disincentive to go into primary care. And so if you're going through, if you're going through med school, you're getting your training and you're faced with the option, boy, do I want to specialize? Do I want to be a neurologist or a cardiologist? And, you're looking at salaries, $400,000 and $500,000, depending on your area, versus primary care. You're a family doc or maybe a pediatrician, you're looking at, hundreds, maybe low 200s, different obviously from community to community, but it's understandable why a lot of people are routing away from primary care, but I would also call that out. I think there's a huge opportunity to shift our attention to keeping people healthy, addressing issues and working with people to maintain their health versus dealing with it after it becomes more acute and there are bigger issues. But this is one, Michelle, where I think we could go super deep into the conversation. But I have a
different conversation about it, because I have it all the time, and I ask people, tell me when the again was, because we've made strides, and were it not for investments in preventative medicine and family medicine, we wouldn't have people. I just had a conversation with a primary care doc this morning. We were talking about a campaign to educate community members on, the changing guidelines for colonoscopies, for example. Yeah. And so we've come a long way in many ways, but we haven't, to your point, we continue to underinvest in primary care. I agree with that wholeheartedly.
Yeah. Well, that gives us an opportunity to do even more to see a brighter future. And I know we're both committed to doing that. But I want to take us in the direction of infrastructure, because I think that's another really important piece of all this. So, whether it's broadband, it's transportation, it's hospital closures, I'd love for you to speak a little bit to how those issues intersect, but how also the impact that it has in terms of access to care in rural areas.
So infrastructure is obviously something that is very important, because without it, hospitals just cannot stand alone. So we've seen some really important investments in health facility infrastructure through the USDA programs. We're really concerned about the funding that will be available for replacement facilities, for example, but infrastructure and broadband is a very important.
So what gives you hope right now in this space? I mean, when we think about innovations and coalitions and community and all of the different solutions that exist out there, what stands out to you and what gives you the most hope right now?
I think that's such a good and important question because I, like probably many of you out there, you wake up in the morning and you have your whole list of reading, and it's not doom scrolling. I'm reading industry information to try and stay ahead of things, and it can leave you feeling pretty deflated. And what gives me hope is that I am surrounded by fellow advocates who are out there every single day and keeping their sights set on the future, and they are fighting for us. They are fighting for their communities. And they have a lot of fight left in them. And so I am really encouraged by those who are saying, listen, we've lived through policy changes before, and we will continue, to push forward and continue to advocate. And I'm hearing from folks saying, listen, the work to bring equity to rural is never over, no matter how strong the headwinds are. So I'm really encouraged by my fellow health advocates out there who are fighting the good fight and taking it to the members, who represent them to their front doors. And so as long as we're not resting, they can't either. And I really appreciate everyone out there who's out doing the same and really working hard to make sure that rural health it gets stronger and remains viable, because surviving is not an option. Thriving is what we're working towards, and you cannot thrive when you don't have the resources you need to stay afloat.
Well, I couldn't have said it better myself, Michelle, and just so grateful for your passion and your dedication and your decades of doing this work. And I do believe that the future is bright. I think we have a lot of work to do, but I agree with you. There are incredible advocates all joined together, some independent, all working on this issue. And I know that we can do better. We have to. Everyone deserves that, but I know we can do better, and I think the future can be bright. But just can't thank you enough for the conversation today and to work together, because, advocacy in groups and coalitions is even more powerful. So thank you again. Really appreciate it.
It's my pleasure, and thank you for having me, and good luck on your new show.
Thank you. For our listeners, rural health isn't a side issue. It is a national issue, and health centers are on the front lines, showing up every single day, doing more with less to make sure that those communities are cared for and connected. If today's conversation moved you, then let's do something about it. That's what we do. It's about policy and advocacy, and you have a role in that. So call your lawmakers, ask for their support for rural health funding, help us fight for policies that make healthcare more equitable, that brings access to care to everyone regardless of their zip code. For more ways to get involved, you can always visit us at advocatesforcommunityhealth.org. And of course, you can subscribe to hear this podcast on a regular basis. Community Health Centers Unfiltered, wherever you access your podcasts. But bottom line, thank you so much for joining us today and listening, and we look forward to having a conversation next time. Thanks.